Okay. So with all of your permission, ma'am, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet is India's most trusted and widely used digital platform, offering a multitude of imaging services exclusively for the doctors. Clarinet is delighted to be chosen as a digital partner for this event organized by Indian College of Anesthesiologists. So today's focus would be role of transthoracic echocardiography in clinical practice. So without any much further delay, ma'am, I would like to hand over the session to you. Can you proceed, ma'am? Over to you.
Thank you, Swastika, for kind introduction of the today's topic. I welcome all the dignitaries on the dais and all the audience, those who have joined this session for today's webinar on behalf of ICA. That ICA is running many activities, not only the academic, but the other activities also, the charity activities, and for the student benefit, they are doing lots of programs in the form of conferences, in the form of workshops, and in the form of webinars. So today's topic is role of echo in the clinical practice. 2D Echo is taking over as a routine investigation for all kind of the cases, not only the elective but for the emergency also. And how it is going to help us in the clinical practice, the topic for discussion is for the today. So first I would like to invite Dr. Minty for presenting her interesting cases, how the 2D Echo has helped us for managing those cases. She is a professor in cardiac anesthesia and critical care, AIIMS New Delhi. Her special interest is complex congenital cardiac surgeries and critical care, ECMO, and medical education. She has multiple publications and many presentations, many publications, not only the national but international too. And significant achievements include editorial board members on the Annals of Cardiac Anesthesia, JOP, JCC, INCCA. She is on the review board members for 17 journal and won 32 award for research work. So she's more interested for the research and she's really doing the excellent work on the side of the research. So I welcome Dr. Minati for today's webinar and to you for the presentation. Minty, you have to share your screen. Amarja, you have to unshare your screen. Amarja, you have to unshare, yeah.
Yes, he has unshared now. Thank you, Manjula ma'am, for the nice introduction. Thank you so much. And I have nothing to disclose because these two are my cases only. So, in the next couple of minutes, I'm going to discuss how the transesophageal echocardiography become my savior. In the first case, we learned that all simple cases are not simple actually. So this patient, she has a history of trauma, 43-year-old female, 11 months back. She developed a femoral artery pseudoaneurysm and came for repair. Her hemodynamics were like heart rate was 98 per minute, blood pressure was 123 by 67, and oxygen saturation was 100%. So we started the case as usual, as for like other cases, like on monitor anesthesia care with some local anesthesia. We injected ketamine 1 mic per kg, injection paracetamol and ketorolac along with 1 milligram of midazolam. However, there was sudden development of the chest pain and hemodynamic instability after they just removed the thrombus. Blood pressure went down to 75 by 55 millimeter mercury, Heart rate increases to 120 per minute and there was a lot of diaphoresis. We started giving oxygen. We thought there might be some volume loss, which was actually not exactly. We supplement 200 ml, then 300 ml, there is no improvement. We gave phenylephrine bolus 50 mics and BP improved only 200 by 70 millimeter mercury. 10 minutes later, she became drowsy. There is no gross ECG changes, but however, there is mild STT changes. Saturation dropped down 98% with FiO2 100 with the marks. Must be 0.6% is going with that FiO2. There was tachypnea. Heart rate was 123 per minute. We gave fentanyl 2 mic per kg, intermediate midazolam and rokironum. We finally intubated her just to make her bit stable. And this was the amount of thrombus which was released from her. Her heart rate was again to bit improvement 123 per minute. BP was 102 by 68. PO2 was on 45 with FiO2 of 1. ETCO2 25, PSCO2 was 21. There was mild increase in the TROP-T. So there are several questions came to our mind whether it is inadequate analgesia. So she developed that, but we give inadequate analgesia as for her body weight and all. Is there any migration of thrombus or if there is anything else? So if you can see, we just because we are in the cardiac theater, we are inside the OR, so we just put a echo. What must be happening? As you can see, there is loss of contractility. Heart is hardly moving. And if you can see, there is mild decrease in ejection fraction of the left ventricle, that is 47%. Mitral valve E by A is 1 is to 1. We looked at the right heart because patient was undergoing embolectomy. So we can see right heart is grossly dilated, right ventricle is grossly dilated. There is D-shaped right ventricle and there is lot of thrombus inside the right atrium. There is some pressed thrombus as well. We measure the RBEF was 34%, fractional area change is 33% and TAPSI was reduced, it was 11 mm. The myocardial performance index was 0.6. The TDI, the velocity is 8.86 and tricuspid diameter is normal range 32 mm. We further studies the PA as well. And while we are integrating PA, we find some organized thrombus in the right pulmonary artery. By that time, patient has improved a bit, and we saw the hepatic system. There is gross dilatation of the IVC. But there is no thrombus in the IVC RA junction. There is hepatic flow reversal. So we shifted the patient to cath lab for further investigation in the line of the pulmonary thromboembolism. But however, we found a triple vessel disease, thrombus in the RPA, LPA, and RA in the fluoro. So a emergency CABG with pulmonary embolectomy was planned. CPB time was 146 minutes, cross clamp 124 minutes, and TCA time was 28 minutes. So you can see the post embolectomy and post surgery CABG, how the heart is contracting. There was a disappearance of thrombi in the pulmonary bed, and there is some improvement of the right heart function, and the tricuspid regurgitation was significantly reduced. And there some reversal of the right ventricular dysfunction, and there is improved the global ventricular function. So when you measure the PA pressure, it reduced down to 65 millimeter mercury from 98 millimeter mercury, the systolic PA pressure. And the right ventricle cardiac output has improved. It was 3 liter per minute. TAPSI was 14 from 11 and myocardial performance index was 0.4. The patient received 0.5 mics of NTG. dobutamine 5 mics per kg per minute, bilirubin on 1.5 mic. BP improved up to 95 to 60 millimeter mercury, heart rate 110 per minute, and right atrial pressure at the skin closure was 20 millimeter mercury. On the 7th post-op day, a TT demonstrated there is significant improvement of the strain pattern and the functional status. So what we learned, every simple case is not simple, and do not hesitate to put a echo probe in the acute cardiovascular collapse. And in this case, echo only saved us. Otherwise, we could thought it might be due to some hemodynamic instability due to some other case, because we have never seen this kind of thing before, because we do massive number of pulmonary femoral embolectomy, but we never came across such kind of case. But this patient indicates some suspicion, so immediately we put an echo probe. And even if you don't have a TT, you can see in the TE, you can see in the TT as well, the floating thrombus. And if there is any suspicion in the echo, you can always shift the patient for the further investigation after managing primarily. The second case is another interesting case. This patient moved from the OT table for the medical management. This case is a 29-year-old male, and this patient presented to our cardiology unit with a history of dyspnea since the childhood, and there was gradual increase in the cyanosis. When the patient came to OT, there was cyanosis, digital clogging, saturation was 97%, there was loud PO2 and PSM over the left lower sternal border. Blood investigation was almost normal except the hemoglobin and hematocrit level were a bit high. That was 21 gram per deciliter and 64% respectively. X-ray, however, shows a little bit suspicious picture. The right upturned cardiac apex, pulmonary bay was full as you can see, and there is increase in pulmonary vascular marking. And TT report showed a malanated VST, tight pulmonary stenosis, and enlarged right-sided chamber indicating the feature of tetralogy of halo. CTO angiography report was also there, which was done 6 months before. There was large subaortic VST, aortic override, right ventricular hypertrophy, infundibular stenosis with confluent pulmonary arteries and without significant MAPCAs. Dimension of the main right and left PH were 30 mm, 28 mm, and 23 mm. So all are in the increasing range. Ascending aorta was 26 mm. And based on all that is nearly to the MPA size was rather more than the ascending aorta. But however, based on this finding, the surgical plan, what was advised by the cardiologist, was intracardiac repair for tetralogy of halo correction. So we induced the case, we put the echo probe. In this 5-chamber view, you can see there is a large perimembranous VST with the bidirectional shunting. So then we move the probe to mitral mid-esophageal RV inflow-outflow view, which again shows the PMBST in a 7 o'clock position with some infundibular thickening. Mid-esophageal aortic valve long axis shows a large myelinated VST, which is about 1.5 centimeter in diameter, almost more than two-thirds of the aortic valve diameter, plus aortic override. Transgastric RV outflow view shows the normal opening of the pulmonary wall with infundibular thickening. Color flow Doppler shows Doppler flow turbulence was noted across the infundibular region. This patient does not have any pedia or coact. So we develop a diagnostic dilemma, that is because of the combination of the TE finding, because that shows a PMBST with a bidirectional shunting, aortic override, infundibular thickening, and normal pulmonary wall with a large pH and increased PVM in the chest X-ray. But by the time when we did the TE, the sternotomy and the pericardiotomy has already been completed. We saw the MPA and aortic size looked similar. So we just discussed with the surgeon and asked him to measure the mean pulmonary artery pressure directly, which was found to be 80 mm mercury. For the radial artery was 83 millimeter mercury, the mean pressure. It was nearly similar. So the diagnosis was revised in the table from the tetralogy of Fallot to a non-restrictive large melanine BST causing increase in pulmonary artery pressure plus Eisenmenger physiology resulting in infundibular hypertrophy consistent with Gasul phenomenon. Cardiologist was called and the case was discussed with the cardiologist and surgery was deferred. Medical management was started with the tablet Bugentan 125 mg per oral BD and tablet sildenafil 0.5 mg per kg per oral QID. TT was again repeated in the 6th month. There is some decrease in the systolic pulmonary artery pressure and the degree of bidirectional shunting. But however, there is no significant change in the infundibular stenosis. It remains the same. At 1 year follow-up, and it's already 1 year over, the shunt was predominantly left to right now. There was infundibular stenosis, remained the same. A room air oxygen saturation was 96 to 97%. The patient is currently waiting for the repeat CT angio and the cardiac catheterization before surgical intervention. So, intraop TE, it plays a pivotal role in confirming the pre-op diagnosis. Otherwise, that day what happened, there was scarcity of the echo probe. So, one probe was not functional. So, we used to have 8 probe in 8 hour, but that day there are 7 probe. So, I just asked for somebody else to give their probe and put it in that patient and find all these findings. So this help in structural, functional and hemodynamic assessment and guiding the management. The usual diagnosis of tetralogy is by the TTE unless the patient has some complex anatomy that can be missed by TTE. Branch pH, markers and the coronary artery anatomy, they are better interpreted by CT angiography, which was done in this case and there was no significant marker also. Benjamin Gasul in 1957, he suggested that TUF can be an acquired defect as a sequelae to large perimembranous VST. In this case, what happened? There is torrential increase in pulmonary blood flow, which gives rise to high pressure, and this retrogradally gives rise to RVH, infundibular stenosis, and subsequent some degree of RVOT obstruction. Both the congenital and the acquired tetralogy have the same anatomical defect, but however, the different physiological implication and the management of protocol. In OL developed PH and RVOT obstruction, surgical correction is required. Uh, in the congenital TF, in the congenital tetralogy of the Fallot. And in tetralogy of Fallot, the malalignment VST causes aortic override, RVOTO, and thus RVH. On the other hand, large malalignment VST causes PH due to left to right shunt as well. In 1% of cases, there is gradual development of the bidirectional shunt, obstruction in the pulmonary vasculature, and the Eisenmenger syndrome subsequently, which lead to failure of the pulmonary vascular bed to undergo maturation, which has happened in our case. And in this case, again, I can say TE again shift us from the surgical management to a medical management, and now the patient anatomy has been changed, and now he is fit for the surgical correction, and he will undergo that. Thank you so much. Little bit about Gaussian phenomenon is acquired mechanism to protect the lung from the volume overload. The clinical course is frequent RTI and dyspnea on exertion, followed by relief of symptoms or gradual development of the clinical picture of TOF or Eisenmenger syndrome. In the congenital TOF, early diagnosis, there is early cyanosis, clubbing, hypercyanotic spell, classical coherent subvert in the chest X-ray due to and empty pulmonary blay in the oligemic lung field. But wherever in the acquired TOF or the Gasul phenomenon, initially the child does not develop cyanosis and clubbing, the pink baby. There is RV apex with the full pulmonary bay because the pulmonary artery pressure is more. And the plethoric long field, like large VST, mild to moderate infundibular stenosis, or the features of Essen-Wenger syndrome. Management in both cases are different. Top with VST with infundibular stenosis needs surgical correction, and the Essen-Wenger syndrome need medical management. So this case signifies the role of echocardiography in the management of such cases. Thank you so much.
Atta.
Dr. Manjula, can I comment? Hello? Can you hear me?
Yes, sir, you're audible, sir.
Yes, sir,
Both
please.
cases were very nicely presented with importance of TE being shown as an important feature of management of these cases. In fact, it appears that in up to 13% of the cases, new findings may be found, which will alter the course of the surgery and management. So this is a very important point which has been highlighted by Dr. Minati's presentation. Thank you so much. Thank you.
Thank you, sir. I'm on sharing my screen.
Ma'am, can I share the screen?
Yeah, I have on shared already.
Dr.
Yes, sir. Dr.
Amarja,
Amarja here.
please start your presentation.
Yes,
We are
sir.
looking forward to it. As everyone knows, Amarja, and she doesn't need any introduction. We are very grateful to Amarja for being present today
Thank you,
to
sir. Thank you so
present
much.
the role of transthoracic echo. Thank you so much.
Yes. Yes. Thank you. Thank you, sir. Sir, just give me a second. I think it is not there. I should leave and again join.
That share option is not coming up.
No, it is not coming. It was there when I checked.
Swastika, please help her.
Yes, sir. Ma'am, have you opened the PPT in the background?
Yes, it is open. But that option is not there. No, wait a minute. Wait a minute.
Okay.
Yeah, now it is open. Can you see this? No, no?
No, ma'am. Now come back to the Zoom, ma'am.
Yeah.
WhatsApp. Very interesting.
Yeah, Zoom.
Yes, ma'am. Now open the share, like click on that share option.
Wait a minute. Here Zoom to solve it. This one.
Yes, ma'am. Now you can share it. Is it?
I have to. This I have to do it full screen or what? This
Yes,
PPT.
ma'am. You can go ahead and like make it full screen, ma'am. Like at first
Yeah, I
share,
have
and
done
after
full
that,
screen.
select that entire screen.
Wait a minute. Something is happening. Okay. 9. There is no share in this.
Hello.
Should I join again? No, there is no share now. Previously, when we checked, it was there, right?
Ma'am, you can also see in this options more.
More. Okay.
Ma'am,
There also you
is
can see the
the
slide share option.
yes, ma'am. Is the Zoom screen is visible to you, right?
Yeah, this is the Zoom workplace, right?
Yes, ma'am. Now go to that mode,
More, yeah.
and from there you will also get the share
There
screen
also you
option.
can see the share option.
No, it is not there. Should I leave and join again?
Yes, ma'am. You can do that once.
Leave.
Minty, have you unshared yourself?
Actually, ma'am has left because she was not able
Because
to
your
find.
screen is showing not unshared. Yeah, now we got it.
Ma'am, now your voice, audio and the video is off. Kindly turn those on, ma'am.
Yeah, can you hear me now?
Yes,
Yes,
we
ma'am. I
can
can
hear
hear.
you.
And you can see the PPT also, no?
Yes.
Fine. So let us start. Um, After the insightful lecture of Dr. Minati ma'am, let us now see how we can procure these images. Like we have earlier learnt a lot many times about transesophageal echocardiography. Let us now put some emphasis on transthoracic echocardiography for clinical practice. See, just now we saw how we could diagnose tetralogy of Fallot, or say the pulmonary artery thrombus. So that is in OR when we have put TEE probe, but also for the pre-op and post-op management, when we don't put TE probe, transthoracic echo comes to our rescue. So let us see how we can procure these images and can be helpful to us in our day-to-day practice. A few pictures are taken from the internet. Echocardiography, as we all know, is very safe, non-invasive, repeatable, and real-time. I'm talking particularly about the transthoracic echocardiography. Echo provides a substantial structural and functional information about the heart. It can be applied in the perioperative period, intensive care units, emergency situations, in traumas, and even as resuscitation aids. It not only assesses the cardiac function but has many more uses, such as defining the contractility of the various structures, like the various chambers of the heart, the chamber size, the hypertrophy of these chambers, then valvular dysfunctions, diagnosing cardiac tamponade, or even diagnosing pericardial and pleural effusions. Now, how to procure these images is very important. Later on we can see how do we estimate the various parameters from that, but let us first start with the views. There are four main views in the transthoracic echocardiography, and the most important first is the left parasternal view. Next is the apical view, third is the subcostal view, and also the suprasternal view. Suprasternal view is more of used by cardiologists, but it is also very important for us, and the importance I will tell you later. Coming to the first view, that is the parasternal long axis view. The patient has to be ideally positioned in left lateral positions so that the heart falls to the towards the chest wall, and we can get better images. Nonetheless, if you have in your ICU or in OT, if you have the patient in supine position, that is also okay. And the transducer has to be placed in the left third to fifth intercostal space near the sternum. So you see, this is the sternum of the patient, and in between third to fifth intercostal space, just say at the level of nipple, even if you put just besides the sternum on the left side, if you put your probe with the orientation marker towards the patient's right shoulder, this is the only and only view where the orientation marker will be towards the patient's right shoulder. In all the other views, it is anywhere other than the right shoulder. So you remember that the parasternal long axis view, your orientation marker has to be towards the patient's right shoulder. And what do you visualize then? Then you can visualize the full left ventricle, the left atrium, the mitral valve, the aortic valve, part of ascending aorta, and the RV. This is in diastole, while this is in systole. As you can diagnose it by during diastole, the mitral valve is open and the aortic valve is closed, and the vice versa in the systole. Also, you can assess the left ventricular systolic function, dilatation and hypertrophy of the chambers, the interventricular septal hypertrophy, mitral valve, aortic valve functions, the descending aortic dilatation, that I will show you how to diagnose that, and pericardial or pleural effusions. See, what I was telling you, there is particular importance of this particular view. In this is something that is very important structure, is the descending aorta. You can see a descending aorta. Any collection which is anterior to the descending aorta is always the pericardial fluid, which is posterior to the descending aorta is always to the pleural fluid. Now coming to the next is the parasternal short axis view. On the same position where we got the parasternal long axis view, just turn your transducers 90 degrees clockwise, and then you visualize the aorta in the short axis. Now the indicator is towards the patient's left shoulder. So when the patient's parasternal short axis view is there, you get such a structure, and this structure is the RVOT here, or the RV here, the pulmonary valve and the pulmonary artery. Here you have the tricuspid valve, the right atrium, interatrial septum, and the left atrium. This is in diastole, while this is in systole, where the aortic valve is open. We should, as cardiac anesthesiologists, we should also know the importance of this particular aortic frame, in which you can also diagnose the coronary cusps. How do you know which cusp is which? The adjacent to the cusp which is adjacent to the RV is the right coronary cusp. Adjacent to the LA is the non-coronary cusp. The remaining one, which is adjacent to, they say, the interatrial septum, is the non-coronary cusp. Now, this parasternal short axis view has three basically views hidden in it, and each view has its own importance. When you keep the transducer at the same place and tilt it towards the left hip, you see this is the mitral valve. Yes, and this is the anterior mitral valve leaflet, the posterior mitral valve leaflet. You can also see the interventricular septum and the part of RV as well. You further tilt the transducer downwards and it shows the anterolateral papillary muscle and the posteromedial papillary muscle. This wall of LV, the walls of LV in this are very useful to know the regional wall motion abnormalities. Also, hypovolemia can be particularly diagnosed in this view. See, you can diagnose the hypovolemia, the global regional wall motion abnormalities or the akinesia or hyperkinesia in this particular view. Also, you can see the hypercontractile ventricle and the kissing papillary muscle sign, which indicates the hypovolumia in this particular patient. Further tilting the transducer downwards gives this the apical view of the LV. So this is the apex of the LV. Very important to diagnose thrombus. This is the same. I have just taken this. Is for the transducer position. In this video, we can see the left parasternal long axis view and the transducer position. Can you hear the voice? The transducer is placed in the left parasternal 3rd to 5th intercostal space, and the pointer is towards the patient's right shoulder. If we turn the transducer clockwise 90 degrees, we see the short axis of the LV with the mitral valve in center. This is the anterior mitral leaflet and the posterior mitral leaflet of the mitral valve. And if we still tilt it inferiorly towards the patient's left hip, we can see the two papillary muscles. These are the two papillary muscles. This is the posteromedial papillary muscle. This is the anterolateral papillary muscle. And this is the LV in short axis. This is the anterior wall of the LV. This is the inferior wall of the LV, the lateral wall of LV, and the septal wall of LV. The segments are anteroseptal, inferoseptal, inferolateral, and anterolateral segments of the LV. Thank you. Now coming to the apical four-chamber view. That was about the parasternal long axis and short axis view. Now coming to the apical four-chamber view. The patient can be in supine position or left lateral position. The transducer has to be in the 5th intercostal space in the mid-clavicular line or say at the apex impulse. Orientation marker is towards the patient's left shoulder now. This view particularly is very, very important for us because this gives you immense information about the patient's heart. The first globular chamber or the largest chamber usually and normally is the left ventricle. Left ventricle is the largest and globular structure. It forms the apex normally. Next is the RV, which is triangular, and it does not form the apex normally unless until it is hypertrophied or has some right heart pathology. This also has a moderator band. This is the tricuspid valve. This is the mitral valve. How do we diagnose? Because the tricuspid valve is situated a bit apically. So this is the tricuspid valve. This is the right atrium. The left ventricle has the openings of the pulmonary veins in the left atrium. So this is how left atrium is diagnosed. What do we assess in this four-chamber view? The ventricular functions, the contractility, dilatation, hypertrophy, and pericardial effusion as well. When you tilt or when you angulate the transducer anteriorly towards the patient's head upwards, then you can get this 5-chamber view wherein you can open the aorta. This is the LVOT. This is the aortic valve, and the part of ascending aorta is also seen in this view. So this is it. This is the view. Now, once you get that 4-chamber view, you counterclockwise, if you rotate it from the apical 4-chamber view, the RA and the RV disappear. Now you get the LV and LA. This is particularly important because the walls change. Wall of RV which you diagnose change. So this is now the inferior wall and this is the anterior wall of LV. Then further, if you counterclockwise, if you rotate the transducer, you will get the 3rd chamber, that is the aorta will get opened. Now coming to another very important view, which is the subcostal view. In this, the transducer is placed in the subxipoid region. The indicator or the orientation marker is towards the 3 o'clock position, and then you can view the 4 chambers. I'll show you in the next slide. And rotation of this transducer counterclockwise and towards the left side displays inferior vena cava in the long axis. So this is the 4 chambers that are seen, the liver in particular here, and the RA, RV, LA and the LV is seen here. IVC can be seen in long axis over here. So this is the subcostal view, and you can see now the IVC is getting opened. IVC is diagnosed when and only it is named as IVC when you see this connection between the RA and the IVC. Otherwise, it can be aorta also. We have some differentiating factors as well, which will differentiate aorta and IVC. But to name it as IVC, you have to see this connection with the RA. Now coming to the suprasternal view, the transducer is placed in the suprasternal notch and the indicator is towards the 1 o'clock position. What do we diagnose here? Very importantly, we have to diagnose these three main branches of the aorta, arch of aorta. This is the brachiocephalic artery, the right brachiocephalic artery, the common carotid artery, and the subclavian artery. This view is particularly important for two things, which is the subclavian artery is here, and your tip of IABP should not cross this subclavian artery. So once you put the IBP, you may put it in OR or in ICU later on in the ICU. So you have to do this, and your tip of IBP should end somewhere here. It should not cross the subclavian artery. This is one important thing. Secondly, PDA is diagnosed in this view, wherein you can see the connection in between the PA and the descending aorta. So your PDA will be seen here somewhere, and this is your cutoff for the tip of the IABP. That is the importance of this view for us. Then these are some more views which you can practice more to get more information from the heart. This is the RV inflow view. RV inflow view. You get the parasternal long axis view and then turn the probe towards the patient's right hip and you get this view. So as we get the bicaval view in TE, in a similar manner, we can see the bicaval types view in this also. So this is the RV inflow outflow view, wherein you can see RVOT, pulmonary valve, and a nice pulmonary artery can be seen here. The RPA and LPA can also be seen here. This is what Minati ma'am showed you in TE to diagnose the thrombus. So that was about how to procure the images. Now, in short, we will just see about the systolic dysfunction because this is a vast topic. We cannot cover the whole thing. So I have taken only systolic dysfunction and I will emphasize a few points on this. Two important criteria how to diagnose systolic dysfunction is mainly the sluggish ventricular contractions, and mainly the walls of LV do not thicken uniformly while contracting. Ejection fraction is normally more than 55%. LV dysfunction is named as mild when the EF is 45 to 55%, moderate when it is 30 to 45%, and severe if it is less than 30%. We all should know about the regional wall motion abnormalities, which indicate the imbalance between myocardial oxygen supply and demand. Normokinesia is when the endocardium moves towards the center of LV more than 30%. It is mild when it moves 10 to 30%. It is severe when it moves less than 30%. Akinesia when it doesn't move at all. The rest of the LV is moving, but some walls of LV do not move. Dyskinesia is when they actually move outwards. Wall motion score index. We have this scoring for normal or hyperkinesia 1, hypokinesia 2, akinesia 3, and dyskinesia 4. You have to sum up all this and divide it by the number of segments. The normal score has to be 1. Increasing score will denote worse diagnosis. EF is mainly determined by 4 methods: eyeballing, fractional shortening, fractional area change, and modified Simpson's method. I have not included this biplane method as of now in this particular presentation of today's, but if given chance, we will take a elaborate talk on this later on. So eyeballing method is also very useful. It is a sure shot method. Cumbis et al. They have said that visually estimated ejection fraction by 2D echography is closely correlated to quantitative ejection fraction by real time 3D echocardiography, and worldwide it is practiced. So when you eyeball, what do you actually see? You see the inward movement of the endocardium. It is nicely seen in the short axis also, and but you can see in the long axis as well, or the apical chamber views as well. So inward movement of the endocardium, thickening of the myocardium, the longitudinal motion of this mitral valve. See, if I've kept my arrow over here, how much it is going longitudinally, that is also seen, upward and downward movement in this particular video, and the geometry of the LV. Okay, so this geometry is symmetrical. So for me, this is a good LV. Coming to fractional shortening is similar, but the internal diameter during diastole and systole is taken, subtracted from diastole to systole, and then divided by diastole LVIDD again. That is how it is taken. The normal range is 25 to 45%, 20 to 24% is mild LV dysfunction, 15 to 19 is moderate LV dysfunction, less than 14 is severe LV dysfunction. We can add 15 to 20% in this to get the ejection fraction also. This is how the diameters are taken, or usually we can take it in this manner also. Fractional area change, which is taken in the mid papillary short axis view, wherein the LV endosteric area is and the LV end systolic area is needed. LV endosteric area minus LV end systolic area upon endosteric area into 100 is the formula for this. Normal LV function is 30 to 45% and impaired when the FAC is 20 to 30%, and severe LV dysfunction if the FAC is less than 20%. So this is how the FAC is calculated. So that was all about echocardiography transthoracic, its clinical use and how to procure the images. And do visit my website cardiacanesthesia.in for more of cardiac anesthesia PowerPoints and notes. Thank you.
Thank you, Amarja, for excellent presentation and simplifying the topic to make our PG to understand how to do the 2D echo and how to take the benefit of this echo imaging for the management of the patients. And not only during the intraoperative period or during the cardiac operations, but even for the ICU and cardiac patients coming for non-cardiac surgeries or even in emergencies, because nowadays we are doing the quick estimation of the heart functions while doing the 2D echo. And Dr. Murli Kanchi, if you are still here, would like to comment for this, I will be happy. Sir, are you around? So we will just quickly see the chat box if there is any question from the audience side.
No, ma'am, there is no
No
questions
questions.
received, ma'am.
Okay, fine. So the few comments from my side that Miss, I'm really happy to deal with the 2D echo assessment for the emergency cases, especially when the cases are trauma cases are coming to the hospital. They are the geriatric patients, are they are the young patients. And it's really helping us to managing the cases and finalizing the management part with the help of 2D echo imaging. So we are just coming to know the heart functions. And the previous speaker, Dr. Minati, has already told us about the role of transesophageal during the intraoperative period. And the simple case may also be turned into the difficult cases. We think it is a simple, but it can turn out to be difficult. So expanding the horizon of transesophageal echo imaging, and which is really helping for management of all kind of the cases, not only in the routine, but even for the emergencies. And the role of cardiologists are reducing in this field because most of the cases has been taken care by the anesthesiologist. And if the cardiac anesthesiologists are available, that is very good. But if they are not available, then even the general anesthesia people are taking care of the patients with the help of 2D echo. So really great presentation by both the speakers, and thank you very much on behalf of ICA. We really thank both of you for the excellent presentation. Thank you once again.
Thank you, ma'am. Thank you so
Thank
much.
you, ma'am. Thank you, ma'am.
Yeah.
Thank you. Thank you.
Swastika, can you
Sure, ma'am.
conclude?
Sure, ma'am. I hope my screen, I am audible and visible to you all.
Yes, you are audible.
Okay. So thank you so much to all the dignitaries present here. Clarity is really glad to have all these brilliant people together in session today. And I hope you all had a seamless experience. So with everyone's permission, I am concluding the session in here for today and looking forward to host you again. Thank you so much.
Okay, thanks a lot. Thank you very much for everyone.
Thank you so much.
Yeah.